Good afternoon, please. My name is Robert Taylor, and this term, the Program for Research on Black Americans and the Michigan Center for Urban African American Asian Research are pleased to host the Group Dynamic Seminar. It's one of the longest running seminars in the social sciences. Before we start, I'd like to mention just a few of the next speakers. So, as you know, for many of us, next week is spring break. After that, Taylor Hargrove, a young sociologist from North Carolina, speaking on the impact of skin color on physical and mental health. And then the week after that, on Tuesday, is our Recruitment lecture, which is sponsored by the School of Social Work. But please note this talk is on Tuesday, not on Monday, and it starts at 2:30. And there's a panel discussion, and you have to sign up for that. If you haven't seen the email about that, I'm gonna send another one out tomorrow. So now let me mention today's speaker, Dr. Marvella Ford. Dr. Ford is a professor of public health at the Medical University of South Carolina, and she's also an endowed professor at South Carolina State, an historically black university. She's the PI on several NIH grants, including the Senate grant on health disparities. She also leads a summer undergraduate cancer research training program in collaboration with 3 historically black colleges and universities in the state of South Carolina. Dr. Ford's research interest includes developing and testing methods to improve cancer surveillance and adherence, and improving informed decision-making for prostate cancer screening. Dr. Ford's lecture today is also co-sponsored by the Gerontology Learning Community in the School of Social Work. What some of you may know is that she was originally scheduled to speak here in the fall of 2017, but Hurricane Michael had other ideas. So let me just note that, the last note that many of you know, Dr. Ford is a graduate of the joint program in social work and psychology. So please, let's welcome Dr. Marvella Ford.
Thank you so much. Thank you. Good afternoon, everyone. I don't have the words to describe the honor of being invited to speak at the location where I received my doctoral degree. So it's an honor and a privilege to be here with you today. And I thank all of you for coming out in the frigid weather, although I guess not polar vortex weather. So thank you. Today I'd like to spend time with you talking about recruitment and retention studies with African American adults and some of the lessons learned. I'd like to discuss 5 topic areas: recruitment intervention testing, retention intervention testing, cancer screening adherence assessment, receipt of surgical treatment for cancer, and participation in cancer genetic studies. In terms of the presentation outline, we'll start with a statement of the problem, followed by a description of the conceptual framework, and then we'll go through the 5 studies: the AMEN project, cancer screening patient navigation study, comorbidity study, surgical adherence study, and feasibility study of breast cancer candidate genes in 3 population groups in South Carolina. And we'll finish with overall conclusions across all 5 of the studies. So in terms of the problem, many of us are aware that in 2013, only 2% of National Cancer Institute-sponsored clinical trials focused on racial and ethnic minorities. And this is a problem because it is not reflective of the proportion of these groups in the population. When we look at cancer incidence rates, these are rates per 100,000 people, we see that the cancer incidence rates are much higher for blacks, particularly for blacks, than for other groups. And yet when you look at the participation of blacks in cancer clinical trials, it's not reflective of the incidence rates in this group. And the problem, as we know when we talk about the equitability of participation in research, is that the benefits and the risks are not equitably distributed across different population groups. And so this results in multi-million-dollar studies being funded with taxpayer dollars when at the end of the day, there's always a paragraph in the discussion section that says we are not sure how the intervention will apply to members of diverse populations, future research in this area is needed. So that's been going on since many years, over 30 years, 40 years. And now we're in 2019, so the question is, when will the future get here? When will we do these studies in these different population groups? And Michigan has always been in the forefront of health equity research, but more of it needs to be done. So the NIH Revitalization Act of 1993 stipulates that when we do studies, we should either include populations at proportions that reflect their representation in the US population or in the geographic regions where the trials take place. So this is wonderful. It's not enforced. So this is a review criterion for study sections, and those of us who serve on study sections make note of this, and that's taken into account in the review, and I think that is making a change. So just as we see, we African Americans are not well represented in cancer clinical trials, and there's a lack of randomized trials testing the effectiveness of different recruitment and retention strategies in this population. So the conceptual framework is very simple. There's been a more elaborate model that was developed by Dr. Jean Ford and colleagues, but it basically takes the same constructs that you see here. So we have sociocultural barriers, which are there are barriers such as fear and mistrust of the researchers, the research institutions where the research is taking place. Economic barriers like the cost associated with participating in studies. Do we hold project sessions in the evenings and weekends where people can participate without losing half a day's pay? Do we provide transportation? Barriers inherent in program design are really barriers inherent in our research design. Did we create the design of the study to be feasible for the participants, or is the design of the study feasible for us and our teams? And then we have individual barriers like denial of disease, feeling like this disease doesn't apply to me, it's not important. Can everyone hear me? Okay, I can talk a little louder. So the first study is the AMEN project, and this is a study recruiting African American men to the prostate, lung, colorectal, and ovarian, or PLCO cancer screening trial. These are some of the publications that resulted from the AMEN project. We count first, second, and last author as senior, but it varies from institution to institution. So the AMEN project design is a randomized trial. It was designed to test the efficacy of 3 increasingly intensive recruitment strategies in recruiting African American men to the PLCO trial. The primary objective of the PLCO trial was to determine whether screening for those cancers reduces mortality. And that may seem to be kind of an intuitive response, but at the time we didn't know. There was no randomized trial showing that screening actually resulted in any reduction in mortality. And the PLCO trial is a 22-year multi-site randomized cancer screening trial that's funded by the NCI. In the PLCO trial, for men, the screenings are for prostate cancer, lung cancer, and colorectal cancer. Prostate cancer screening is done using the prostate-specific antigen test, which is a blood test. And the digital rectal exam, if I do this, you know the digit I'm talking about? Lung cancer is done by chest x-ray, and then colorectal cancer by flexible sigmoidoscopy. So we focused on African American men aged 55 to 74 years of age who were community residents of southeastern Michigan and northern Ohio. This is our schema. So we started with a pool of 42,312 people identified through a mailing house. Some of them were ineligible, 2,880 were ineligible, and then we were not able to contact 21,662, leaving us with 5,370 ineligible patients after screening, and then those eligible were randomized to one of the 4 study arms. So Arm D was the usual care arm of the PLCO trial, and in Arm D, the initial letter that people received was from the U.S. Department of Health and Human Services, inviting them to participate in the PLCO trial. That was followed by an eligibility screener conducted by either an African American or non-Hispanic white interviewer, And then a baseline packet was mailed to assess comorbidities and family history of cancer. And then the completed baseline packet was returned. The problem is that only 50% of the baseline packets that were mailed were returned. So arms A through C are variants of the usual care arm. In arm A, we used an enhanced intro mailing. So here we worked with Mr. Dave Bing, who was a former Detroit Pistons basketball player. At the time, he owned a company in Detroit and employed a lot of people. He was very well respected. He later, as many of you know, went on to become the mayor of Detroit. So the first letter, we met with him. He thought this was a very important study. So the first letter the participants received was from Mr. Bing. It had his picture on it. It talked about the importance of African American men to their communities, the importance of screening and being screened. And that was the letter that the men received. We worked with African American interviewers to conduct the eligibility screener in arm A, arms A through C. In arm A, we mailed the baseline packet, and then we only received 50% of the completed baseline packet. In arm B, we again used the enhanced mailing, African American interviewer. Here, we asked the baseline questionnaire questions over the phone. It took 40 minutes to complete the baseline questionnaire. People stayed on the phone and answered all the questions. However, we only received about half of the consent forms because the IRB still required mailed consent forms. In arm C, we had the enhanced intro mailing, African American interviewer, but in arm C, we worked with the Baptist Ministers Council of Detroit and vicinity. And they have 750 churches, and they gave us permission to work with any of the churches under their jurisdiction. And so we looked at the zip codes of the participants, matched them to the closest large churches in the area, and then had church sessions at those churches. We invited the men to come out. We did not recruit from the church population, but we used the churches as sites. And we completed the baseline questionnaire and the consent form. We also worked with Mr. Lonnie Johnson from the Michigan Department of Public Health, who came down. We started doing this every Saturday, and then we went to every other Saturday for about 3 years. He would come down from Lansing to give a presentation on the health of African American men in Michigan, because the Public Health Department had just published a report. And so he came down and gave a very community-friendly presentation. So we addressed some of the barriers in the model by providing transportation to project meetings for Arm C. We worked with a luxury car company, and the men came in and they felt very proud and happy that we sent a luxury car for them. And they said, wow, I must be important. You didn't just send a taxi. They felt really special. We addressed the individual barrier of denial. That's why Mr. Bing's letter said, as African American men, we are more likely than other men to die of prostate cancer. It's important for us to get screened. We're important to our communities. That was to address denial of disease, that I'm not going to get this disease. We worked with the key community leaders like Mr. Bing and the church leaders. And again, we emphasized the importance of the participants to their families and communities so that they could participate, if not for themselves, but for their families. We addressed barriers inherent in study design by gathering baseline information over the phone interview or at the community-based project session. And one thing about the session is the participants said they enjoyed meeting other participants. They liked meeting others who participated in this trial. And then we addressed fear and mistrust by tailoring the recruitment strategies to the population. We used population-based strategies working with a mailing house. We formed partnerships. We included research team members with backgrounds similar to those of the potential participants, and we conducted follow-up telephone calls. And I wanted to point out, our protocol was to make up to 50 calls to each participant. And most of the literature says that is entirely too much. For this population, they said maybe the 20th call, oh, this must be really important. You keep calling me, so you really do want me to participate, right? They liked the fact that we were persistent. So what we found is that the mean age of those contacted was slightly lower than those not contacted, but within those who were not contacted, we were able to reach within those who were not contacted, more of them were in the younger working age group. And then also we had a higher percentage of moderate to high income participants than low income participants. And what we found is that the arm C, which had the highest amount of face-to-face contact, produced the highest recruitment yield. It was more labor intensive, required a lot more effort, but it produced the highest yield. So we feel that the screenings may have been an incentive for men from lower socioeconomic status groups, but we could not offer the screenings as an incentive because we were testing whether they had any impact on mortality, but they still may have been viewed as an incentive. In study 2, since we worked so hard to recruit men, we decided to come up with an intervention to retain African American men in the PLCO trial. And here we used a case management patient navigation approach. These are some of the publications that came out of the patient navigation study. I wanted to point out that our navigators, Ms. Vernetta Randolph is deceased, but Ms. Linda Hopkins Johnson, those were the navigators, and they're included in the manuscript. So the rationale was that when we contacted participants in the Amen project, we saw that they had a lot of human service needs like food, heat, things that could have hindered them from participating. So in this study, we developed the intervention to actually address some of those potential barriers. And we worked with the men. This is the same PLCO trial population at the Henry Ford Health System site in Detroit, Michigan. We worked with the 703 African American men in the intervention arm of the PLCO trial at that site. And we randomly assigned them to the patient navigation intervention group or to the control group. This is the schematic. We randomized the men. They were randomized either to control or intervention group. So in our intervention, the navigators spoke with each participant at least once per month by phone. I can tell you that over the 2.5 years of the study, the navigators made 14,938 telephone calls to the participants, to the agencies that they worked with to make sure that the participants had the services that they needed. And also we included the wives of the participants in this trial as well. So the men who were randomized to the navigation intervention, their wives were randomized as well. Because in the Amen study, we found that the wives were the gatekeepers of the phone. They were the ones who answered the phone. And they wanted to know why this young woman was calling asking about their husband. So instead of trying to explain it over and over, we're with Henry Ford Health System, we just included the wives. And if they had any needs, we navigated them. We used tracking strategies, the ultimates at the time, these were what we used, Switchboard, and then whowhere.com. We used logistic regression to test for interaction between income and randomization group for each of the 4 types of screening tests. And then all overall comparisons were determined to be significant at the p less than 0.05 level, and all within income level comparisons were considered to be significant at the p less than 0.025 level. There were no statistically significant differences in age, education, income, marital status, or work status between the intervention and control group members. So what we found is that the intervention had had no effect on participants with moderate to high income and a major effect on participants with low income. So participants with low income in the intervention group were much more likely to be adherent to the PSA, to the digital rectal exam, to the chest x-ray, and we didn't see any finding for the flexible sigmoidoscopy, which I'll explain. So just to describe some of the services that people requested, we had a lot of requests for assistance with food. The navigators, we asked them to spend 3 months before they ever called a participant developing a resource file. We made an A to Z list of resources that we thought older adults might be in need of, including childcare, because many of these were grandparents raising their grandchildren. And we asked them to identify agencies for every need, and also to identify a contact person in the agency, so that when they referred the participant, they would say, call Mrs. Smith at the area agency on aging and here's her phone number, instead of just saying, call the area agency on aging, here's the number. It's better to have a direct point of contact. We called all of those representatives to introduce ourselves, or the navigators did. They introduced themselves, and so when we had our first call, we were ready to go with the referrals. But people needed help with heat. We made a lot of calls to the energy company, DTE, to make arrangements for payment plans to get people's electricity turned back on, because in the middle of winter they didn't have any heat. We had one couple, the husband was in the intervention arm of the PLCO trial, so he had been screened. He had a diagnostic workup and he was determined to have prostate cancer. He chose not to get treated. So he was, and that was his right, he had all the information and made a decision not to get treated. So he was at home. His bedroom was upstairs, and it got to the point where he couldn't navigate the stairs anymore. So he was in his bedroom upstairs all the time. His wife was visually impaired, and the navigators had the sense that the home was really cluttered. So they tried to send people to clean the home, but the wife wouldn't let them. The people were outside on the porch knocking, and they called the navigator, but the wife wouldn't let them in, even though she had originally agreed to. So that was fine, that was her choice. The problem was their son was stealing from them, but again, he wasn't physically hurting them, he was stealing their things. But one day the navigator who was assigned to that case called, and the wife said, "Oh, a pipe must have burst because I'm standing ankle deep in water." And the navigator said, "Well, what are you doing?" And the wife said, "Well, I'm getting ready to make toast. I'm going to plug in the toaster." And the navigator said, "Please stop." She came to me, we called Adult Protective Services, we sent them out. The husband and the wife were taken out of the home to a skilled nursing facility. They were on one floor apart from each other, only one floor away, and they stayed there until the husband passed away. So these were pretty serious things that people were dealing with, and if we had ignored, if we could have just done the trial and not even known what they were dealing with. But this is the reality of people's lives, the extent of things. I thought when we started the study that no one was going to ask for help. I was worried about that. I had no idea the extent of the needs that people had. So men with lower income levels requested more services than other men, and to have a successful patient navigation intervention requires time to select and hire the navigators, to train them, develop the resource file, make contacts with people in the agencies, to make sure that they know about the study and they knew the navigators, and also to circle back. So the 14,938 calls came in circling back with the people at the agencies to make sure that the needs were met. The navigators also made a lot of medical appointments for the participants. So in study 3, the next, as you know, every study leads to additional questions. So the next study was, what about chronic conditions? We've recruited men, now we found a way to retain them. Are people with chronic conditions or comorbidities more or less likely to adhere to the screenings? And this is a really critical question right now, because there's a lot of debate now about the use of chronic conditions as screening and as part of screening tools, because the problem is a lot of studies exclude people with chronic conditions that are prevalent in diverse populations. So you wonder, well, who is this sample that they ended up with? These super healthy people, they're not representative of the population. And sometimes the comorbidities don't even have anything to do with the study outcome. They're just, people are used to asking about comorbidities and using them as screening tools, but they're really excluding large groups, large numbers of diverse populations. And just last year, I'm on some National Cancer Institute committees, and on one of them I brought this issue up, and Dr. Warner McCaskill-Stevens, who runs the a group at the National Cancer Institute, invited me to go to the NCI to talk about this issue. So I was nervous coming here, and I was nervous going to the NCI to talk about this issue to the NCI, which is my funding agency, but they did ask me to go, so because she's concerned about it. It's we keep saying that we want to increase the diversity of trials, but if we're excluding people with diabetes, and we're excluding people with hypertension, and we're excluding people with conditions that are very common in diverse populations, then it's difficult to increase the diversity of the trials. So here we wanted to just see, do comorbidities have an impact on people's adherence in the trial? And so this is a publication that came. You'll see they're in chronological order. This is a publication from the comorbidity study. And so again, we use the same sample of older African American men in the PLCO trial. the same 703 men who were in the patient navigation study. And so on that baseline questionnaire where the comorbidities are assessed, there's a question about smoking. And this is to determine whether someone is a current smoker. And then this is the list of comorbidities. So you can see the long list here. This is what people were asked about. So out of this whole list, I'm only going to show you the ones where we found any type of even marginally statistically significant results. So for the first is current smoker. So when we look at current smoker, there's a marginally statistically significant difference where current smokers in the intervention group were less likely to adhere to their prostate-specific antigen screen. Chronic bronchitis, which is associated with smoking, when we looked at the digital rectal exam, again, only marginally statistically significant. And then we see chronic bronchitis, which is associated with long-term smoking, statistically significant difference in adherence to the chest x-ray. We're having a negative impact on adherence. And then this is the arthritis one for flexible sigmoidoscopy. So what we think is that maybe people with arthritis didn't want to lie on the table to get the flexible sigmoidoscopy. It might have hurt their joints. And so that's what the explanation here. For the smoking, smoking was the only comorbidity that had any impact on adherence. And we think that the reason we saw lower rates in the intervention group is because these were the men who were assigned to the navigator, and the navigators were talking to the men about quitting smoking, and so they might have felt guilty and felt, and also smokers are less likely to engage in preventive health behaviors, even though they were enrolled in a trial, because sometimes there's a fear that something will be found associated with the smoking. But other than that, we did not see any negative effect. So our results show that once they're recruited, these baseline comorbidities did not have any negative effect on adherence. And so, other than smoking, so that unless the comorbidity is directly linked to the outcome that's being studied, I think it's a good idea to rethink our lists of comorbidities and think about why we're excluding people, unless there's some type of either medical or biologic reason for that you think there might be an association between that comorbidity and the study outcome. There's really not a need to exclude people. And the fourth study is a study on surgical adherence. And so here we combined data from the South Carolina Central Cancer Registry with the South Carolina State Hospital data. And we looked at predictors of surgical resection in patients with localized non-small cell lung cancer. So these are people who have stage 1 through 2 early stage lung cancer. And in these patients, surgery is done with curative intent. So that's, if you're going to be diagnosed with lung cancer, you want to get diagnosed with stage 1 or 2. That's when you can actually intervene and make a difference. But what we saw is that when we looked at the list of factors, I should point over here sometimes, I guess. When we looked at the list of factors that the literature suggests are associated with likelihood of receiving surgery, we saw that even when we controlled for age, marital status, comorbidity, poverty level, insurance status, African American race still had a significant and independent impact on likelihood of receipt of surgery. So African Americans are still 43% less likely to receive surgery than non-Hispanic whites, even after controlling for all these factors. So that meant that we were losing a lot of people unnecessarily. There were a lot of people who were dying who actually could have received surgery and had a chance to live. So that led to this publication and also to the R01 that we currently have going on. So I will tell you the story of our R01 grant. It started off, we called it the Southern Lung Cancer Study, because we started with 4 sites in South Carolina and 1 site in Georgia. This is a publication. So the goal of this study was to test the effect of a patient navigation intervention on, we had a usual care group, and then we had the group that was assigned to our enhanced protocol-driven patient navigation intervention group. We only had 100 participants in each arm, and our study mediators, these are all based on the literature, are health-related quality of life, state anxiety, fatalism, social support, self-efficacy and communication with healthcare providers, trust in physician, intention to undergo LDTCI, I'll explain what that is, and satisfaction with the decision made. So these are factors that the literature suggests would mediate receipt of surgery in people with lung cancer. LDTCI stands for lung-directed therapy with curative intent. So our outcome initially was surgical resection, and that's where the physicians will kind of cut the chest open, go into the lung, cut out the diseased part, take out the tumor, and then sew the healthy parts of the lung back together. More and more sites, as the study began, were using stereotactic body radiation therapy, or SBRT, which is where a targeted beam is used. A targeted beam of radiation is used to just cut out the diseased part of the lung. That was very good because patients who physically wouldn't qualify for a resection could now get SBRT, which was great. So we worked with our statisticians to change the study outcome, not just to include SBRT as the study outcome, and then we just called it lung-directed therapy with curative intent, meaning resection or SBRT. So our primary outcome is receipt of LDTCI. Secondary outcomes are receipt of surgical and/or radiation oncology consultation, because we thought, well, if we can at least get people to speak to the surgeon or to speak to the radiation oncologist, that's a step forward. Time to LDTCI in patients who received it, satisfaction with care received, and time to death. So these are the measures that we have going on now. So we started with 5 sites. So identification and recruitment of study participants. The problem is, after a year and a half, so when we started the study, I thought, when we got funded, I thought we're going to have to come up with some new study aims because we're going to finish recruitment in 2.5 years, and then we're going to need to come up with some new aims to use up the rest of the time. What are we going to do with all that extra time? We're not going to give the money back. We'll come up with new aims. We'll do new analyses. So that was my only concern going into the study, was that we were going to end early. So let me just say that the study was funded in, I think, 2012, and we're in our 3rd no-cost extension right now. So we were in year 1.5, and we had recruited 20 participants. So anyone who knows the NIH, you know that pretty soon, what was the next step that was going to happen from them? They're going to come knocking on our door saying, hey, what's the deal? Give us the money back, right? So they're not going to fund a study where only 20 people out of 200 are recruited in a year and a half in a 5-year study. They're going to pull it, and they'll give the money to somebody else. So I went to a conference and ran into my colleague, Dr. Kate Weaver, from Wake Forest University. And she said, how are you doing? And I said, oh, doing great, but you know, I have this study, and in a year and a half we've only recruited 20 people. And she said, you should run it through NCORE. So Wake Forest is an NCORE research base. And I said, that's a great idea. Because my MUSC Hollings Cancer Center is an NCORE minority and medically underserved site, but the research base that we're affiliated with is Wake Forest. So I will talk to you about NCORE. If you have any opportunity to run a study through NCORE, I would highly recommend it. It's an organized machine. So NCORE is the National Cancer Institute Community Oncology Research Program. This is a group of sites all over the country. They are funded through the National Cancer Institute. They're community oncology programs, not academic centers. So they're out in the community where the people are. In the initial study design, based on our grant from the NIMHD, we were giving the usual care sites $100 to offset the cost associated with recruiting each participant, and we were giving the intervention sites $2,000 to offset the cost of recruiting and navigating each patient. Once we linked up with NCORE, we didn't have to give any site any money because NCORE gave all the sites $2,000 to offset the costs of enrolling each patient. So you can't pay you can't pay to enroll a patient, but you can pay a site to offset the costs of their staff time spent in enrolling patients. So that was one great advantage. The other advantage is that all of these sites, these NCORE sites, have to complete a certain number of cancer care delivery research studies. And those are, believe it or not, they're few and far between. There are not that many. So they were excited to participate in this study. So the NCORE network has 7 research bases, and they have 46 community sites. As 12 are designated as minority and underserved, and their patient populations are at least 30% minority. So I wanted to take us to this, just to show you on the map. If I can do this properly. So the NCORE sites, this is a map of the NCORE sites in the country. And if you click here, the beauty of the NCORE sites is that, I think I wanted this one. Okay, we'll take this one as an example. So this is Las Cruces, New Mexico. Well, they are linked with Albuquerque, Gallup, and Santa Fe. So when you get one site, you also get all the sites that they're affiliated with. It's a wonderful, wonderful network for those of you who are in cancer research. And so even with the NCORE sites, we still ran into a problem. So you would think, oh, this is great, they're out in the community. We're looking for African Americans with early stage lung cancer. Again, I thought, oh, our problems are solved. This will be great. Our problems were helped. They weren't solved. Even within the NCORE sites, they did not see a large denominator of African American patients with early stage lung cancer, stage 1 through 2. Most of the African Americans that they saw had stage 3 and 4 lung cancer. So we had to develop a whole strategy for working with the NCORE sites. We had to figure out how to identify patients further upstream to get them into these cancer centers so we could even screen them for eligibility to get the diagnostic workup, get them into the trial. So we called it academic detailing to identify their referring physicians who were referring into the cancer centers. We mailed them letters, we did flyers, we told them take baskets of muffins over to their offices, show up. We had the coordinators, and it was, this was a big culture change for the coordinators at the cancer centers. They're not used to doing anything like this. So we had to be very respectful, and we had to say, we know that you run a lot of cooperative group trials, you are experts at running trials, but this is a different population. And these strategies that you've used before with other groups aren't working with African Americans because they're not at your centers. And if we don't employ these strategies, we won't meet our accrual goal. So we had to reach out to primary care physicians, diagnostic radiologists. I'll go back to lung cancer screening programs, nuclear medicine, pulmonologists, bronchoscopy suites, pathologists, cancer registries, general surgeons. You can see the list. What was surprising, there were 2 things that were surprising. One was how many different types of physicians we had to reach out to in order to identify African Americans, because they weren't at the community oncology sites. So I think the next grant has to be getting people into these sites. We're going to have to navigate them into the sites. My colleague, Nestor Esnaola, who's now at Houston Methodist, said he has enough gray hair from this study. He doesn't want to do anything else with early stage lung cancer. But I think we have to, because we've got to figure out a way to successfully have a whole grant that just focuses on testing strategies to navigate patients into even these community oncology centers. So what was surprising was these, how many people here have heard of lung cancer screening programs? So not that many. So I thought this was wonderful. Medicare covers lung cancer screening programs. So I thought this was going to be, when they came up 2 years ago, Medicare approved funding, and I thought this is going to be great. We're going to get so many people now, we'll meet our accrual goal. Well, it turned out most of the people who came through the lung cancer screening programs were non-Hispanic whites, and not that many people came through the programs. The other thing is, when African Americans did come through, several of the sites told us that they had African American patients who came for lung cancer screening who were diagnosed with stage 3 and 4 lung cancer, coming in for screening. That is appalling. That's, the other thing that was surprising was, I think at least 2 of the sites recruited from the emergency department. So I would never have thought of using the emergency department to recruit for patients with lung cancer. But they each recruited about 3 people that way. They had people coming in with car accidents, broken legs, who were diagnosed with lung cancer as an incidental finding because they had a scan. You know, again, I think that's appalling. That's how you find out. You break your leg and then you find out. That's how you find out you have lung cancer. So the navigators identified and eliminated the patient's real and perceived barriers to care. And again, we're sticking with that model. So financial and economic barriers, the navigators addressed insurance coverage, transportation, linking them with local resources to provide transportation, giving them information, sitting down and talking with them about lung cancer, what it is, what the treatments are, what the options are, communication and language, building a trusted relationship. They called each patient at least once a week. They only had about a 3-month, maximum 4-month window to navigate, because from the time of diagnosis to the time of surgery should be a maximum of 4 months. So this was a very condensed navigation effort. They helped navigate the patients through the healthcare system. We talked to the navigators, especially the ones that may have been the big city in a rural area, that because we here in Charleston, which has a metro population of 750,000 people, that a lot of people are overwhelmed driving to Charleston for their medical care because they're coming from a town of 2,000, 2,500 people. And so then it puts the 750,000 in perspective. Even though it may seem small to us, to them they call it going downtown, the big city. So we even have to navigate them, meet them at the parking structure, and walk with them into the clinic because they're overwhelmed and they're afraid. And then working with them to show them that we're on their side, we're there to help them. So we, to sort of quantify what navigation is, because there are a lot of navigation studies, but when you ask what exactly went on during the navigation, sometimes you can't get a clear sense of what the navigation was. So the National Cancer Institute had funded an initial set of sites to run navigation studies. And Dr. Beth Calhoun was at the University of Chicago at the time, or Northwestern, I think. And she gave us the NCI's barrier plan form, which was a paper and pen form that was used to help guide the navigators in navigating the patients. We took the form and entered it into REDCap. So now it's user-friendly, it has branching logic, and it serves as a real guide to not only guide the navigators, but also quantify exactly what they were doing to navigate the patients. So as you can see, we had weekly check-ins. If there was no barrier, then the person said no barrier. For every single barrier mentioned, there's what's called a barrier plan form, where the navigators checked the box for everything they did to meet that need. And then there are this is only part of it. There are text fields also where they can write in, called Mrs. Jones. She told me to call back. We'll call back. So they have notes to themselves. We also, in REDCap, are capturing the amount of time the navigators are spending navigating each patient. So that at the end of the day, we're going to do a cost analysis to actually show how much it costs to navigate the patients. This was very helpful. We just finished our design paper of the navigation, and I think being able to quantify it really helped to standardize the protocol across all the navigation sites. And also, it's helping the navigators because at least 2 of them got promotions because they were able to, they took the data out of REDCap and they printed it out and they took it to their supervisors and said, look what I'm doing. And the supervisor said, wow, I didn't realize you were doing all of this. So they got promotions. Because it's one thing to say I'm working with, when you have a meeting, I'm working with Mr. Smith, I'm helping with transportation. But when you show I made 10 calls here and 20 calls here, and you actually show what you did, you can quantify the navigation. So these are our active study sites currently. The study is going through December 31st of 2019. So you can see we went from 4 sites in South Carolina and 1 in Georgia to now Minnesota, Tennessee, South Carolina, Pennsylvania, Louisiana, Delaware, Georgia, North Carolina, Illinois, Virginia, Kansas, Michigan. Nevada should be somewhere in there. There should be a Nevada site as well. So we did meet our accrual goal. We just met it earlier this year. So, funded in 2012, 7 years later. But here's the problem. You can see that we pre-screened 5,071 people in the usual care arm, 4,192 in the navigation arm. Our goal was 100 patients in each arm. We worked with our statisticians. We actually enrolled about 110 because we enrolled people with probable or proven non-small cell lung cancers. Not everyone has a pathology confirmed lung cancer diagnosis before they go to surgery to have the tumor removed. So there were a few people whose tumors weren't classified until they actually went to surgery. And some of them were either found not to have cancer at all, maybe they just had an enlarged lymph node or something. Some people had stage 4. So there we had to exclude, so we over-enrolled to end up with 100 in each arm. But you can see that when we look at screening 5,071 people to have 307 potentially eligible for enrollment, we only had 3 criteria for enrollment: African American race, 21 years or older, and probable or proven non-small cell lung cancer. So most of the patients who came to these sites were not, the reason for exclusion primarily was that they were not African American. But we screened everybody. We screened all of them. And then you can see that our consent rate is about 70%, both across arms and overall. So the last study is study 5. And this is a feasibility study of breast cancer candidate genes in 3 populations in South Carolina. This is a publication that came out from that study, or I should say publications from this study. Here we have a large research team because this is a transdisciplinary, multidisciplinary study. So here we were looking at, and we talked earlier today about testing genetic polymorphisms and in racial disparities in breast cancer. So until recently, African American women were less likely to be diagnosed with breast cancer, but more likely to die from breast cancer. And just recently, unfortunately, the incidence rates of breast cancer for African American women rose to those of the incidence rates for white women, so not a good thing. But African American women are also more likely to be diagnosed with triple negative breast cancer. So most breast cancer types are hormone receptor positive. And most treatments are designed to either keep the body from producing the hormones that stimulate and feed the cancer, or they prevent the body from uptaking the hormones that are circulating in the body. For hormone receptor negative breast cancer, some people have been treated successfully, but the prognosis is not good. We just don't really have a great treatment for hormone receptor negative breast cancer. And African American women are more likely than other women to be diagnosed with hormone receptor negative or triple negative breast cancer. There is Dr. Fumi Olopade in Chicago is doing great work. She's from Nigeria, and she's done great work with Nigerian women and with women in the Chicago area in treating triple-negative breast cancer, but for most patients, the prognosis is not good. So in South Carolina, we have a population called the Sea Island or Gullah population. Has anybody heard of the Sea Island or Gullah population? So a few people. So this is a group, they're the most genetically homogeneous group of blacks in the United States. So many of you know that most of the African Americans in the United States passed through South Carolina. And the Gullah or Sea Islanders preserved their ancestral makeup because they were on the barrier islands. I don't know if, how many of you have heard of Hilton Head Island? Beautiful resort area, right? Did you know that land was owned by black people? All of that land was owned by black people. Those barrier islands were considered throwaway land. They were like junk land. Because of the hurricane, I couldn't come because of the hurricane last year. The hurricanes would come through and we didn't have good building codes back then. Everything would get flattened. And you couldn't really grow things there. It's windy. I mean, you're on a beach basically. So those were throwaway land. They were given to the Africans. So they lived on the barrier islands. And we didn't have fancy bridges like we have now, so you had to travel by boat, which didn't happen that often. So because they were on the barrier islands, they preserved their culture, their heritage, and their ancestry. And when you go to South Carolina, you notice there are some certain facial features that you see over and over and over again. And there are certain names of families that have been there, the Simmons, there's certain names, and these families that were there a long time married each other. You know, the Simmons might marry, the Pinckneys might marry the Simmons, and so there are facial features that are very similar. There's just not as much admixture. The Sea Islanders have about 3.5% European admixture compared to up to like 16% for African Americans. So very genetically homogeneous. So the question here was, we know that African Americans are more likely to be diagnosed with triple-negative breast cancer than non-Hispanic whites, but what about the Sea Islanders? So my hypothesis, you've already seen how my hypotheses go, right? And sometimes I have to readjust them, but we're going to finish recruiting in 2.5 years. What will we do with all that time? So the hypothesis today, I thought that that we would have Sea Islanders on one end, non-Hispanic whites on the other end, and African Americans in the middle, because the African Americans represent a mixture of the Africans represented by the Sea Islanders and the non-Hispanic whites. So I figured maybe the Sea Islanders have the highest likelihood of having triple-negative breast cancer, and then African Americans and then whites would have the lowest. So this was just a very small feasibility study. Our goal was to recruit 30 African Americans with Sea Island ancestry, 30 African Americans without known Sea Island ancestry, and then 30 non-Hispanic whites. These were women diagnosed with breast cancer in the last 18 months, recruited through our cancer registry. We've talked about triple-negative breast cancer. The 5-year survival is 77% compared to 93% for other forms of breast cancer, and occurs more frequently in African American women. So the Sea Islanders, we talked a little bit about them. They are from primarily the west coast of Africa. A lot are from Sierra Leone. So you can see this basket. Historians and genealogists have gone from Charleston to Sierra Leone and found the exact same patterns in the baskets in Sierra Leone. The food, they have their own language, culture. This is a book called Gullah Fauna. Oops. Let me see if I can. Gullah Fauna means Gullah for you. That's part of the language. They have their own Bible in the Gullah language. I just purchased this book, not because I'm not a cook, I can't cook, but I wanted to read the stories. I went to Amazon and read the preview of the stories, and there are all kinds of stories about the Gullah culture. And so they were brought to Charleston because most of the white settlers of Charleston were from Barbados. So they were usually like the third or fourth son and they weren't going to inherit any land. So usually the firstborn in a family would inherit the land. Well, Barbados, there's only so much land to go around, so the third or fourth sons went to Charleston and settled there. They got there, and Charleston is very swampy. So they were thinking, what can we grow here? And they thought, rice. And then they said, oh, but we don't know how to grow rice. So then they went to Africa, and you can see the signs that are, you can see the signs that were actually posted back then. We're looking for Africans. They were called Rice Coast Negroes, because they had the engineering expertise to develop a rice field and create a levee and create the gates to raise and lower with the ebb and flow of the tides so that the rice fields didn't get overwatered or underwatered. And there's a certain type of rice called Carolina Gold that is only grown there, that is, it's like 200 years old, that the Africans brought with them from Africa and grew. So now we have the Sea Islanders. We have at the Medical University of South Carolina a Sea Island Family Studies Advisory Council. So anybody who's going to do a study with the Sea Island population has to go to the council and give a presentation. And the council has to approve working with the community. So we went and presented our study. So we want to look at Sea Islanders, African Americans, and non-Hispanic rights. Our question is, are there frequencies of these selected single nucleotide polymorphisms that are associated with risk for breast cancer subtypes defined by estrogen receptor, progesterone receptor, and HER2 expression? Do the frequencies differ among the three population groups? So we looked at 5 SNPs on the 19p13 locus of BRCA1, and then 2 SNPs on the 5p12 chromosome. And we are, in terms of statistical analyses, we just did descriptive analyses looking at frequencies and 95% confidence intervals. So when we went to the Sea Island Council and we said we want to do this study, and they said great. And we said we're going to ask them questions about ancestry, and they said great. We're going to ask about where their parents were born, great. And we're going to get a saliva sample, and they said ooh. They said, you know, it's an important study, you can do it, but we don't think anybody's going to give you their saliva samples because that's a bodily fluid. They're not going to share it. So we didn't know what was going to happen. Our initial definition of Sea Islander was that both grandparents had to be born in the Sea Island region. And the way we defined Sea Island region is we used the published definition of 30 miles from the most proximal point of the coast. And so we used Google Maps and actually physically measured the distance and then coded every city, town, hamlet in South Carolina as either a Sea Island location or a non-Sea Island location. However, we found that most people didn't know where all 4 grandparents were born. So we went back to the literature, back to the Sea Island Council, changed it to having both parents born in the region. You were considered Sea Islander. You were considered a non-Sea Island African American if 0 parents were born in Sea Island regions. We had a 2-step or 2-phase recruitment process using our cancer registry, which identified the participants for us, contacted the physicians of the patients to get passive consent, and then we contacted the patients to invite them to participate. We identified 365 people in that time frame, and we ended up with 42 European Americans and 95 African Americans, 29 of whom were Sea Islanders, and 66 were non-Sea Islanders. So we didn't see any difference in the saliva samples from Sea Islander versus non-Sea Islander African Americans. They didn't seem to have a problem. We used DNA genotype for the saliva kits, and we took their instructions and blew them up and made them really like large font, blew up the picture, and changed the language. We reduced it down to a 6th to 8th grade reading level, all the instructions. We kept the same format, but made it a lot more user-friendly. And we also had them call us if they had any questions. It was funny. We had one sample that came through with a chunk of hamburger in it, and our person who was doing the analysis said, "Please tell them brush their teeth first." So it was kind of funny. But so we went back and told them. But So what we found when we looked at the Sea Islanders, this is, when we looked at the triple negative, the frequency, there was no difference between the Sea Islanders and the non-Hispanic whites. The outliers were the African Americans. When we looked, this was, and when we looked, so we found that the Sea Islanders, in terms of their percentage of hormone receptor positive breast cancers, they looked a lot more like the whites than they did like the African Americans. So it's taken probably 3.5 years to figure out what to do with this. So after reading and reading, I know we had lunch and talked about the importance of reading, and I know you said you have like days set aside where you just read. That's what I was doing, reading article after article on ancestry and disease. And finally, the light bulb went off, and I realized this is an immune response, or hypothesis again. The paper's under review. This could be an immune response issue. So African Americans as a group are only 400 years old. All the other racial groups and ethnic groups are much older when you look at evolutionary history. The only reason we have African Americans is this is an artifact. Like, I hate to say we're an artifact, but this group really is an artifact of slavery. It's, if things had progressed naturally, it would have happened over millions of years. You can look at the UK. They have some, I don't know what they call them. We say African American, what would they say? African Britain? But I don't think they have a huge population. They have some. They have Africans, and then they might have some African Britons, like we have African Americans. Nowhere, if you look at the Netherlands, look at all over the world, there are always a few, but you don't have this huge group. The only reason this huge group exists is because of slavery. And it exists because of the economics of slavery, where the slave owners were trying to make money. So they would go down to the slave cabins at night and sexually assault the slaves. And then the children would be born. They made a decree that race follows, the child's race follows the race of the mothers, which the National Center for Health Statistics still uses. And then they could sell their children and make money, make a lot of money. They had this term, I found it in an article or a book. It said it's cheaper to breed than to buy. So it's a lot cheaper to go down to the quarters and create your own property than it is to pay for shipping all the way from Africa. Plus, eventually the US outlawed importing Africans. But South Carolina ignored that and was the last state to import Africans well after it became illegal. They were still doing it. But so you have this influx of European genetic makeup into African genetic makeup, like almost overnight from an evolutionary perspective. And so the immune response that would have occurred naturally over time, over this long period of time, didn't have a chance to develop. And so all of the disease risks that were associated with the influx of the European genetic material into the Africans, it's like smallpox on a blanket. You haven't developed the immune system. It's going to kill people who haven't developed the immune system to deal with the smallpox on the blanket. It's the same, it's you introducing all these propensities, disease propensities. So it's just one way to explain why for many different chronic diseases, diabetes, cardiovascular disease, kidney disease, these diseases are just so aggressive in African Americans. And even when you control for adherence to medication, and you control for access to care, and you control for doctor-patient community, you control for everything, African Americans still have worse outcomes. It's just one contributor to that explanation, that we're still developing an immune response. And one of my colleagues said, we're going through a process of natural selection. It's what happens from an evolutionary perspective. And so many people have premature death. These diseases occur on average about 10 years earlier in African Americans than in non-Hispanic whites. And the mortality rate is so much higher in African Americans. So that's a possible explanation. That's what I'm working with right now. Of course, we want to do a larger study, so we'll be writing up a larger grant to do probably samples from Georgia, Florida, and South Carolina to get a larger sample to replicate the study. So we saw that the percentage of cases with hormone receptor positive breast cancer was lower in the African American subgroup than in the Sea Island or non-Hispanic white subgroups. And the less genetically admixed groups, both Sea Islander and non-Hispanic whites, had a lower percentage of triple negative breast cancer. So across all 5 studies, what did we see? There's a lot of diversity among African Americans. Dr. David Williams always says 2/3 of African Americans are not poor. I always say, do the math. African Americans make up 12% of the US population. If every single African American person were what we call poor, it would still be only a small percentage of all the poor people in the country, in spite of what you see in political ad campaigns. You just have to do the math. So ethnic differences, there are ethnic differences in African Americans. Sea Islander versus non-Sea Islander is just one. Jamaican versus non-Jamaican. There are all kinds of ethnic differences. And it's also important to recognize gender and age and cohort differences. We saw that African American men will participate in cancer clinical trials if we employ intensive recruitment strategies, and that patient navigation approaches can be effective in retaining men once they're recruited. We saw that baseline comorbidities didn't really affect people's adherence to participating in the trials, other than smoking-related comorbidities. And so we really want focused recruitment strategies for African American men, in this case, and including the wives or partners. And having a high level of commitment, making study sites more accessible, and having funding and support for investigators conducting the studies. So we already saw this, that the navigation intervention was more effective among men with lower incomes. They needed more assistance. And so African American men with baseline comorbidities are good candidates for participation in longitudinal cancer screening trials. And again, we hope that the patient navigation intervention will increase surgery adherence rates. We can't look at those analyses yet until December, but at least we have the design paper. And so these feasibility studies can really highlight factors. I know a number of you are doing feasibility, you're doing focus groups, you're doing formative research to identify successful strategies. I think that's a great approach. And then we don't want to have definitions of ancestry that are so stringent that they exclude large segments of the population. And actually moving forward with a larger grant, we'll work with Dr. Rick Kittles. He's one of our consultants, and he's now with the City of Hope, who does ancestral informative marker analysis. So he actually can go in and he can code the samples for their the African American samples for their ethnic backgrounds. So we'll actually use that as well as the self-report. And I'd like to acknowledge the program coordinators and program managers and program assistant. Thank you very much for your time. So I'm happy to take any questions that you have. Yes.
So for study 4, I noticed that in the drop-down list of barriers to recruitment, one of the options you had listed was literacy. So I was wondering how you define literacy and what proportion of people listed that as a barrier to.
That's a good question. I don't know what proportion of patients listed literacy, so that was more being able to understand what the doctors were saying. It's like health literacy, and being able to understand the information that was given to them about lung cancer. The number one barrier was fear. Fear, which was surprising to me. Transportation was the second, and then the third was, I think, making medical appointments or access to the healthcare site. But I will look at the percentage of literacy. It wasn't very high on the list, but maybe because they had a navigator who was reading everything with them, everything that they got from the doctor, the navigators are going over it with them and making sure. But that's a great question. Thank you. Yes?
Thank you so much for this talk. It was really helpful. So this is kind of a small detail, but in your last study you talked about the advisory council saying, oh, they're not going to want to give saliva or spit samples. And it's definitely something I've run into in my research. I do spit samples in my studies, and I've definitely gotten some like mistrust or what are you going to do with this sort of data. So I'm just kind of wondering, the advisory council advised that, but you went forward with the saliva sampling. So how did you address that with your participants?
I'm thinking maybe it's because the person who made the calls to them was African American. She was an African American woman, and she's actually from, the thing is, I don't know if she would, say that she's from the Sea Islands, but the way she talks, like a lot of people will not say I'm a Sea Islander, but they talk in the dialect. So that's how she talks. So they could hear that, and I think they felt comfortable talking with her. And I never said that to her, but I think that really helped a lot. It's having somebody from the community who did the phone calls and administered the survey. What we found is we had more mistrust from African Americans when the registry contacted them than when we contacted them. So I don't know, it might be just going back to the interviewing and who we had doing the interviewing, but she was very warm and spoke in the dialect and could make them laugh, put them at ease. So I think that's really key. And you know, the interviewers, I think we need to just look at the structure too. And they're very important in these studies, and I think we should recognize them. Thank you. Yes.
So interesting, thank you.
Thanks.
I would like to ask you to say more about the intervention's use of the wives. First of all, I'd like to understand more about how you involve the wives, and then could you say anything about the differences between those men who were in a couple versus those who were single? Did they maybe do better if they had a wife who was part of the study or not?
Interesting. So the wives, because they were the gatekeepers, so I had to write scripts for all of the calls. Like we had the first month call, second month call, third month call, so I wrote scripts, and our programmer programmed them for the interviewers. And so on the first script, the navigators would say, hello, I'm so-and-so. Thank you for enrolling in the PLCO trial. I'm your, I think we call them a resource person. We didn't say navigator. I'm your resource person. I'm here to help. Some people have told us that they've had these kinds of needs, you know, X, Y, and Z. Are any of these a problem for you? And then that got the conversation started. After they discussed his needs, then the navigator said, is there anyone, do you have a spouse or a partner that I could speak with? Because I can help, I can serve as a resource person for her as well for these needs. And then he would call and put the wife on the phone, and the wives loved it. They had a lot of medical appointments made for them, and it just made a team approach. That's a really good question about who did better, the men with wives. I actually haven't looked at those data, but that would be a good analysis. So, thank you.
Sure.
We had some, I was just thinking about this the other day. Some of the men were lonely, so the navigators really, they were troopers. They were on the phone. I had to get them headsets eventually because their necks were getting, because the men were lonely and they would just talk and talk and talk. And one day I was at the back of our suite and a man came in with flowers. And you saw that one of the navigators was the late Ms. Vernetta Randolph. And he said, is Miss Vernetta Randolph here? And I was about to say, yeah, she's right. But the other navigator she used to be a security guard in our building, and she was just very personable. She immediately said, who? Oh no, you're the wrong. Let me take you down to the security station and we'll try to find who you're looking for. Just quick thinking. Because I was going to say, oh yeah, I'll take you to, she's right over here. I wasn't thinking that he was one of the participants. So maybe that gets to it. That was an issue. They had to remind, because the participants would say, oh, I want to come and see you. I want to bring you some candy. I want to thank you. And they had to say, this is a telephone-based intervention. I'm sorry we can't meet face-to-face. And he knew that, but he just wanted to. So it's kind of sad in a way, but it just shows how lonely and isolated. And so I think the navigators, I think that would be a great analysis to see, because based on those responses, I think that probably did make a really big difference in their lives.
I'm wondering with the prostate screening, it seems like there's kind of pros and cons to prostate screening, and in terms of maybe the possibility that the cancer could be very slow growing and will never really have something else they might die of, or also there might be side effects for treatment, including incontinence and erectile dysfunction. So it's not all to the good. And I'm just wondering, was that part of the discussions with the doctor, or was it assumed that if they were getting in this nice car that they were going to get?
Oh no, that was absolutely.
Okay.
We had to talk about pros and cons. That was that's the whole purpose of the PLCO trial, was to see whether prostate cancer screening even reduces mortality. So that was a major point of discussion. So the thing is, it's not clear, it wasn't clear at the time whether it reduced mortality, but when you look at African American men, the mortality rate is so much higher. What we could say is, here's the mortality rate for African American men, here's the mortality rate for white men. So, and we know for a fact that most of the data really came from white men in terms of the effectiveness of screening and reducing mortality. But it's one of the questions, and I'm just going to answer it about the PLCO trial, is they have not yet done a sub-analysis looking at the effectiveness of prostate cancer screening only in African American men versus only white men. They said they were going to do it. I haven't seen it yet, but that needs to be done because the mortality rate is so much higher. In South Carolina, the mortality rate for prostate cancer is 3 times higher for black men than white men. So we have to give them all the facts and tell them we don't know whether it's going to work. We couldn't use screening as an incentive because that's what we were testing. And so we had to be really careful and really train the navigators and train all the interviewers. Like, please, you can't say, oh, if you participate, you'll get free screening. Can't use it because that's what we're testing. So, great question. Thank you.
I'm just wondering, curious about, did you hear from any of the participants in any of your studies if they were asked, do they ever get asked? Because a lot of times I hear that, no, they're not being asked, the doctors are not asking us to participate in clinical trials. Is that something that came up?
We didn't ask them, no. Right now, so I'm running a statewide cancer education program, and we just made a new partnership with the African Methodist Episcopal Church. So they just wrote us into their 3-year health ministry plan. So we've agreed to do once a month, we call them Moving Up, MOVENUP. I got a lot of flack for that name, but I thought at least people remember it. So people say it sounds like George Jefferson, like Moving Up. But it's Moving Up, and so we've published some papers showing that, so we go out and we tell people about cancer risks and ways to screen, and we have a whole module on cancer clinical trials. So I took a module that was developed by the National Cancer Institute and tailored it to make it more appropriate for African Americans. So not just changing the pictures, but changing the language, including a whole section on the Tuskegee study, Henrietta Lacks. What I do here in those sessions is things like, oh, I think my doctor might have signed me up for a study, but I'm not sure. And so we just stop, because that's why we're there. People still think that their doctors can enroll them in a trial without their knowledge. So we don't get I haven't heard people say, that's a good question to ask, is has your doctor ever spoken to you about a clinical trial? Maybe we can add that. I think that's great. Do get a lot of, I think I might be in one, my doctor signed me up, I think. So, thank you.
Marvella,
Yes.
could you tell the audience a little bit about your summer program?
Yes. So we have a grant. We started with a grant from Liberty Life Foundation that allowed us to. Oh, here's one of our students. Oh my gosh! Can you stand? This is one of our summer students. I knew you looked familiar. Can you say your name, please? Brianna, right?
Okay, yeah, I'm Brianna Jacobs. I'm in the School of Public Health in my MPH and Health and Nutrition program.
I think we should clap for you. This is one of our summer students. So we started with a grant from the Department of Defense, or from Liberty Life, to bring 2 students in for over 5 years from Voorhees College, which is an historically black college. Then that led to a Department of Defense grant. They used to have a program called HBCU Collaborative Undergraduate Summer Cancer Screening Program. So that grant was awarded. I had to go in every 3 years and compete for it. That was awarded 3 times, and that allowed us to bring in 4 students per year. Then we just recently got an R25 about 2 years ago, and that allows us to bring in 16 students per year. So all of the students, we developed a cancer research curriculum. We have 4 areas, 4 cancer types, 2 areas. We focus on hormone-related cancer and then HPV-related cancer. So under hormone-related cancer, we're looking at breast and prostate cancer. Under human papillomavirus-related cancers, we're looking at head and neck cancer and cervical cancer. The students also take a GRE, so it's a pretty rigorous program. We built in the graduate record exam, so we contract with either Kaplan or Princeton Review, whichever is cheaper that summer, to come into our university 1 day a week, and they deliver a 3.5-hour training session. We also have information about the Sea Island or Gullah population, so we have a Gullah with Sea Island tour, and the students go in a van out into the islands and learn about the Sea Island community. Am I leaving anything out?
No, that's yeah.
Oh, working with your research project. So each student is assigned to a Hollings Cancer Center researcher, and they develop a research project that they complete over the 10-week period. And several of the students have published their research projects. And Brianna was part of the R25. We call it SC Check, South Carolina Cancer Health Equity Consortium, and that is our grant. Our partnering institutions, because we don't have undergraduates at the Medical University of South Carolina, it's a graduate and professional school, are South Carolina State University, Claflin University, and Voorhees College, which are HBCUs, and then University of South Carolina. And Brianna was at University of South Carolina and wanted to come here, and I said, I would be happy to write you a letter to go to Michigan. I don't know if the letter did anything, but anyway, she's here and doing well. I stared at you the whole time and I thought, wow, she looks... But then when you asked about the students, I made the connection. That's awesome. Thank you for coming.
So we're going to let this be the last question. Again, I want to thank Dr. Marvella Ford.
Okay.